Oh, there's a big group.
We're on. Can you hear us okay?
Yes, I can.
Okay, perfect.
Yes. Awesome.
Okay, we're going to mute.
Okay. So feel free to get started. Thank you.
I'm just going to quickly say, this is Sheila Marshak from MU AHEC. I asked David Pohl if he would be willing to speak, and I just really appreciate his time and insight that he's going to share today. He's the Assistant Professor of Family and Community Medicine at SLU. He's also the Director for the Center for Interprofessional Education and Research. So thanks so much for being willing to be our speaker today.
Thank you. Well, welcome, and I appreciate the time, and I do want to say thank you to all the people who submitted questions. You had some great questions, which we will definitely get to. I'm going to try to go through the slides in less than half an hour, so we'll leave another half an hour for addressing the questions that were submitted, and then also some time for open questions if there's additional ones that come up. So if anything comes up as a question during the talk, please feel free to just jot it down, and I'll ask about those at the end. The other thing that Sheila may have mentioned offline is that I did have the opportunity. Somebody's got their computer not muted, so I'm getting a couple things for their lunch there.
Can you speak up a little bit? We can't hear you, and we're maxed out on volume.
Okay.
Thank you.
I'll try to project right at my microphone. How's that? Does that make a difference if I'm talking like this? Okay.
That's better.
When I started at St. Louis University 15 years ago, my role was with the AHEC program. So it was a great introduction in terms of what was happening across the state, as well as really my areas of interest were engaging our students in community-based work, both clinically and from a longitudinal service standpoint. I started off my own personal career path as an exercise physiologist and got into a private program that combined medical management, exercise, nutrition, behavior change, stress management for patients with very serious chronic disease. Pretty much been written off by their physician as nothing else we could do to medically manage your condition, and was able to see tremendous results. The part of me that started to get inspired was realizing there was a lot of people out in the community who did not have the resources or access to a private program, and felt that being out in the community was more of my passion. So I got a master's in public health, started working in a nonprofit in downtown Los Angeles for the American Indian community, which was a phenomenal experience and life-changing, and then have been here at St. Louis University for the last 15 years. And I'm going to share a little bit today in terms of different aspects of interprofessional education and why we're doing this. I think some of this will provide some of the basis for the questions and answers that you guys have submitted. And then if there's additional things that I've learned as we go along, I'll be sharing some stories both in the presentation as well as in the question and answer part, which I think might be more most interesting and definitely more helpful. So again, describing what I'd hope that you can be able to do by the end of today, describe why health profession programs must prepare students for interprofessional education and practice, discuss the connection between IPE or interprofessional practice with effective, safe, and quality outcomes in terms of how we address making the healthcare system better. Describe 5 practices or principles of effective team-based healthcare, and describe at least 3 attributes of effective, specific to effective teams. And then when we get into the question and answer session, we're going to get into different aspects, again, of the application, different clinical settings than just the ones that were introduced in the Mitchell article, and some of the other great questions that people had. We all, and I lump myself in here as a faculty member at the university, but really for those of you studying as medical students and other health professionals for the future, you have tremendous the big challenges, and that I believe it's our responsibility to help prepare you for those. We can't do it all, but we can help you be ready for some of the things that you're going to have to face, and having the foundational skills to be able to continue your ongoing lifelong learning. But definitely improving patient care and outcomes. That's one of the big areas that we know we spend a tremendous amount on healthcare, and we don't have the best outcomes. And there's a tremendous shift in healthcare delivery that is focusing now on the outcomes. 15 years ago, when I was in the nonprofit sector, this was a shift from federal funding with nonprofits, where we said, oh, great, here's $1 million, go out and do case management, care management, nursing care management, all of these diabetes programs. And I did, and I documented them really well in terms of how many I delivered. After being there for 2 years, there was a shift and said, we'd love to continue to give you $1 million to do this, but now we want to know what the impact of your programs are. And if I couldn't show that, then I had 2 years with a lead time to be able to say I would not be funded at the same level. So being able to put together those things it's not something new. It's something that has been in the grants and nonprofit world for a long time, and it is now really showing up in both medical care and medical education. We can't just say that we delivered really good stuff to you guys and that we did our best, but what difference did it make, and did it help prepare you better? Being able to address errors and adverse outcomes. Nobody goes out to be able to practice and create errors or adverse outcomes for your patients, but they continue to happen at a very high rate. So understanding what those are and what we can do about them. Hospital readmissions, some of you know now this is a big area for cost at the hospital. If a patient is readmitted within 30 or 60 days, depending upon their condition, CMS, Medicare, Medicaid will not pay the hospital for the care that they receive. So being able to coordinate care across transitions of care, across different professions, across into the community, really important. Medication adherence is a big one. Patient self-management, use of the ED, and then I added one to the slide here. The big goal that we all have to figure out what this means is how do we provide higher value care at a lower cost, and that those two things are related, and we'll talk a little bit about that as we go through this. Hopefully most people have heard of the triple aim, if not the full quadruple aim. Being able to look at sometimes these get truncated. I found that being able to talk to students and learners about, and even clinicians about, more of a full definition of them makes a difference, because they can start to see where they can do something about that. So it's not just care or patient experience, but how do we improve individual patient care and the outcomes? And that's again where how effectively we collaborate and how we engage with the patient in terms of patient-centeredness and shared decision-making. All of those things change the patient experience, but they also change the outcomes of that care process. Patient populations and community health outcomes, I like to separate these out because some of you may or may not end up looking at larger community health issues, but all of you will have patient panels. So when the triple aim talks about patient populations, they're also talking about subsets of your entire panel, right? So if you say, when I was in Los Angeles, I had 3,000 patients or clients in my program. I had rounded off 600 of them were diabetic. So my patient population of diabetics, I had to be able to look at, not just the ones who showed up monthly for a diabetes workshop, but what was happening across those 600 patients as a patient population. Same for kids and immunizations, women's health, diabetes care, heart disease, whatever it might be that your specialty area is. Are you able to look across your patient panel and determine what are the best practices to be able to improve care? Where these two things start to come together. One of the things we're doing, I sit on a steering committee for our clinical practice group at St. Louis University. We're looking at our overall patient outcomes with diabetes and hypertension. And we say kind of a plateau of outcomes with hemoglobin A1C control or hypertension control. So one of the questions we started to ask was, well, is there anything underneath the big number? And what we discovered when we had our data team run an analysis of all of the patients, race, ethnicity, socioeconomics, payer, gender, everything, we found that there was different factors underneath. The diabetes outcomes were separated, and there was a disparity by race, right? So our African-American populations were getting less control of their hemoglobin A1C than our white and Caucasian patients. Hypertension, we found, was not a race issue. Across all races and genders, it split socioeconomically. So depending upon their payer, people with low socioeconomic status or low income were seeing much more poor results with hypertension control. Big point being that there's not one best practice for everyone or every population, but there's not one factor that's always the same or influencing every aspect of a health outcome. So being able to understand those things and understand what you can do about them as an individual provider or as a member of a practice team or practice group is very important. Cost-effective care, we'll get into it a little bit with a couple of examples. And then the last one, it really relates to the quality of the care and also error reduction, which is how do we continue to focus on improving provider and care team well-being. A couple of you commented about the teamwork. You can see where that makes a difference there, but does it really contribute to the other things? So we'll talk about that. But yes, we cannot continue to have a workforce that either is burned out or experiencing high rates of depression and self-harm in terms of physicians or other places. Nurses also have a tremendous amount of turnover in their workforce. So being able to take a look at these things as part of the effectiveness of care as well as the cost, really important. What we tried to do is integrate all these things, and this is an approach. I don't need to spend too much time in terms of what we're doing with SLU, but we have tried to integrate all of these components into being really a service as well as education center and documenting the outcomes of those educational experiences. And now we're branching into documenting outcomes with clinical care team partnerships. One of the questions that came up from a couple different people was, what are some of the barriers? And I would say this is one of them, is that there's a tendency to think that interprofessional teamwork and collaboration is separate from good practice or good care. As long as I learn to be a good physician or a good individual health professional, that's teamwork stuff is this extra piece. And on one hand, you can say that no aspect of teamwork is going to cover for the fact if you don't have good clinical skills, right? But one of the things we know is that your ability to work with your team and be able to utilize all the different people who are now involved in the complexities of care and the healthcare system is really important. And it does impact the patient, and it does impact the safety of the care, and it definitely impacts your ability to get consistent quality outcomes. So seeing this as part of what you learn as part of how you practice as a physician or as a healthcare provider, really important. Hopefully a number of you have seen this. It's hard with this. Usually what I do is I ask the people I'm talking to is what stands out for them around this definition. And the answers I get are the ones that are underlined. But the idea that how do we engage in our practice that enables us to continue to learn about and from and with others, and that there's two goals to that. One is that we have a constant goal to collaborate more effectively, and we have a goal to improve the outcomes. So how do we continue to work better as a team and get better outcomes for our patients? And that are there different ways of approaching that or different perspectives that will contribute to that occurring? The interprofessional practice part is, again, how are we utilizing the skills and the professional training of everyone on our team? One of the things that I often say to our health profession students in our second and third years that I work with is that if I don't know what you do, I'm probably not going to ask you to contribute to helping my patient, right? So each of us has to be able to advocate. Just because you're a physician doesn't mean that you you don't have a specialty area of something that you do really well, something that you contribute, something that you're passionate about. Same is true of nurses or physical therapists. We have a phenomenal physical therapist on our faculty. She is also an expert in wound care. We have occupational therapists who are experts in dealing with fetal alcohol spectrum disorder. So it's not just that they're an occupational therapist. The same thing, a big one comes up with dietitians. As health professionals, we can all classify ourselves as nutritionists. We can even get certified, if that really means anything. But having a licensed dietitian really means that we've got someone who can take a look at the health condition, the medication status, and the needs of the healthcare team and help contribute to those. But it also becomes important that the dietitian be able to advocate that they do a lot more than just a dietary consult. So being open to, one of the barriers is that many health professions think they know what a profession contributes to a care team or care of a patient, but it may be limited in their understanding and not really utilizing the full scope of training of that professional. So being open to that and being able to continue to learn, very important. I'm not going to play the Josie King story. I'm going to let you guys do that if you like. It's a tough story, but it's a mom's experience. And again, top-notch hospital, Johns Hopkins. Some of you may have seen this one before, but it's really points out that even healthy patients in top-notch hospitals, top-tier hospitals, can have accidents happen and errors, and those occur because of breakdowns in communication across the team. A big essential part of what happened here in this story, if you haven't seen it, is that Josie, as a young girl, as an infant, falls into a bathtub that's being run for an adult and suffers high degree burns over the majority of her body, and spends a significant amount of time in the hospital and is recovering from those, but then starts to have complications. And the way that the parents were engaged and that the way the care team participated was challenging, didn't lead to the best care. The other part was that there was a breakdown in documentation. Verbal orders were provided for hydration and no narcotics for the pain that the baby was experiencing. And since those weren't documented in the chart, a nurse that came on shift didn't know that for sure. And not only was Josie tremendously dehydrated, but she was given a shot of narcotics, and she ended up going into a coma and dying. So it was a combination of breakdowns in multiple areas. To the parents' credit, one of the things that they did was they joined the healthcare team at Johns Hopkins, and a credit to the Hopkins teams as well, and they created an entire process for families to be able to call non-emergent codes to be able to be engaged in and determine levels of concern and how they could actually participate better. And integration is one of the things we have to do. We're seeing that there's a shift from, yes, please encourage or participate in interprofessional education. It's now becoming a requirement for programs across the health professions, and has a component in terms of accreditation at medical schools and residency programs as well. A big part of it comes into the residencies around quality and safety. So shifting from basics to what do we know about effective healthcare teams, and what is it that we can learn from, or how do we utilize this information to be able to better look at preparing you to go into a clinical setting? Or when you are in a clinical setting, how can you use this information to reflect on what's actually happening? One of the things that I found to be most helpful is based upon the literature around high reliability care, which is basically getting consistent quality outcomes. Consistency and the quality is related to three different components: your individual professional skills, effective teamwork skills, and effective systems and processes of care. One of the things I like to acknowledge for people, and that many physicians have experienced this, is that we have taught for a long time that your individual professional skills are the primary driver of quality outcomes. And that in the hidden curriculum or the unwritten curriculum, this is often reinforced. So if we take those two other components out of the equation on top there and say, consistent quality outcomes are primarily the result of your individual professional skills, when there's a deficit in quality or when there's an error, whose fault is it? In case you haven't said it out loud, it's yours, right? And that what we know is that 70% of errors and adverse outcomes occur because of breakdowns in teamwork and effective systems and processes of care. And the ones that are happening on the individual level are predominantly because they've developed a workaround that is to address the poor teamwork and the poor ineffective systems. So how you are prepared to be able to look at these things and be able to see them and be able to do something about them is really going to change how you enter into your future practice. One of the things that the medical students here at St. Louis University have found to be helpful from a mental model is it's exactly the same clinical and critical thinking skills that we're asking you to develop as a clinician, saying, what are the symptoms that you're experiencing or seeing, right? What are the signs and symptoms? Based upon your training, what does that tell me about possibly underlying concern, health issue, diagnosis, right? Once I have the diagnosis, what's the best way to treat that? And that's what you're developing as a clinician. If we can start to help you be able to use that same critical thinking process with respect to teamwork and systems, that's going to be a huge shift in helping us to change healthcare. So are you aware of and can you identify signs and symptoms of effective teamwork or ineffective teamwork? Can you diagnose what's going right or not going right? Being able to say, here's the underlying problem and here's what I can do about it to make it better. And if you're doing that and you have the skills to be able to do that, that directly results in better outcomes for your patients. A couple things we know and some great questions related to the Mitchell article. Effective teams across multiple settings are strong in these 5 areas. And one thing I like to mention and work through with our students is shared goals in no way supersedes what your professional contribution is. It's just that what is the goal for the overall care team? Are we working towards that same goal? In our seminar program for 3rd years, sometimes I'll get students to come back and say, this team was really critical of each other. There was a lot of blaming. But one thing I can really see is that they never really sat down and said, this is our primary goal to get to as a patient and what the patient wants and what we're striving for as a care team. And that there was not a understanding of who was supposed to be contributing to what, or what were those shared expectations of deliverables from the different professions. So for the student to be able to see that the lack of a clear goal and the lack of rule clarity directly resulted in a change in care, but it also resulted in how the team worked together to serve the patient, was to me a really valuable start. Being able to, again, diagnose some of those aspects of what's working and what's not. These are there. I'm not going to read them to you, but again, based upon shared goals, I'll give you an example in an outpatient setting because this came up as one of the questions. I was working with the health centers across the state on integrated care and trying to look at how do we integrate behavioral health and primary care at the rural health and federally health qualified health centers. We gave them a scenario of one of their patients, typical patient, a diabetic patient who kept showing up in the emergency room for wound care on their feet due to their diabetes. But one of the things that came up was, okay, we have to get the patient direct care right now, what they need. But as a team, the administrator, the clinic manager, the nurse practitioner, the medical assistant, the physician, the behavioral person, they started to talk about what's really going on with this patient. And what they realized as a team was that they came up with the idea that the patient really doesn't understand what the difference or how to utilize the healthcare system in terms of primary care, urgent care, and emergent care. And that they kept showing up in the emergency department for things that were truly primary care related, right? They had an access issue. The patient didn't feel they could get in, but they also had an understanding. So what they decided as a team is one of their primary goals was whatever they were doing with the patient to take care of their immediate needs, they would also be doing education as a whole team of talking about what do you come to primary care for? What do you go to urgent care for? And when do you go to the emergency room? So being able to see these things and take a look at them in the lens of patient self-management really changes who needs to contribute, what are the roles for different professionals in doing that and helping with transitions of care. Another example here in St. Louis, a number of years ago, I want to say 9 years ago now, the Regional Health Commission and the Integrated Health Network, which is our safety net collaboration partners, came up with a proposal to look at what if we put patient navigators in the emergency department. On a national average, patients who are in the emergency department told to follow up with their primary care providers, about 20% of them actually make it back to those visits. So what they decided to do was specifically start saying, well, if we have a social worker or a MSW or a trained coordinator there to actually work with patients and navigate those barriers to getting back to primary care, and they work as a part of the team while the patient's still in the hospital, what can we do? What impact could we have? And over the course of the next 3 years, they found that they went from a 20% average show rate at primary care to 60 to 70% of those patients were actually showing up for their primary care visit. So being able to take a look at that and then being able to inform the system as to what are those barriers, how many touches does it really take, and what makes it work, if rather than just, again, blaming the patient for being non-compliant, it takes a lot more in terms of the system. So understanding what those roles are and how we can work together and communicate effectively, and then determining what measures or processes tell us that it's working or not, really important. I'm not going to go into all these, but these are also attributes. If you're, again, putting on a lens of being able to see, how do I get more people to contribute? Is there a good climate, a positive climate? Are we actually getting other people's voices? Do we support innovation? Or is one of the comments when someone comes up with a new idea, everybody says, we don't do it that way here, right? We do it this way for whatever reason. Or we actually create a culture where med students aren't even comfortable saying, well, why is it being done this way? And what they find out is it's always been done that way. And there might be a different way. Right. I had a fourth-year medical student who I worked with on quality improvement for the last few years. He was on an away rotation and he's going into ENT, really interested in surgery. He was on a rotation and they were doing a high volume of both adenoids and tonsils. And he came back and shared with me that as a fourth-year student, he discovered that there are 2 different machines that are specifically used for each of those surgeries. And he was asked to participate or allowed to participate in actually doing running the machines for a surgery and on a tonsillectomy. And he stopped and looked under the table and said, the attending physician said, what's the problem? And he said, well, I'm still not used to all the pedals and they're all marked the same underneath for both machines. And chief resident said, yeah, it took me like 2 years to figure out which ones were which, and I had to keep checking. So while he was there on a 4-week rotation, he actually worked with the chief resident. The pedals were all made by the same company, but they got different caps and labeled and be able to color code them so that the machines and the pedals were aligned and everybody went in. There was no possibility of, or drastically reduced possibility of human error because they hit the wrong foot pedal and used the wrong machine for tonsillectomy or adenoids. So again, even as students, you can make a difference if you know what types of things to speak up about and what to identify. These are just definitions of those attributes, how you can participate, what can you do to create and support other professionals having a voice and feeling that they're an active member of a care team. Big part of the measurable part is trying to go from, well, we did this service to what's the output of that and then what's the outcome of it, and then being able to say, here's the impact it has on all of our patients and all of the care that we deliver. And I'll give you an example in just a little bit of where that is. There's just some reference things. The IPEC, if you haven't heard of them, it's a great resource to start to look at competencies around interprofessional collaborative practice and how ready can you be to step into collaboration. There are 4 domains of these competencies and being able to understand. Not being competent in these areas, again, is one of the biggest barriers. Thinking that or being trained that everybody's out to do their own work. I did my PhD in education and curriculum design. And one of the things that I did as I was looking at education was I realized that many of the things that we've tried to address in disparities and equities and cross-cultural care are the exact same issues when it comes to interprofessional care. That each profession is socialized into their profession, attitudes, ways of thinking about things, ways of looking at things, ways of hearing about symptoms, ways about asking, ways of engaging with patients and others. And it becomes a whole socialization into a culture of medicine, nursing, social work, rehab, pharmacy. And that when we try to communicate, many times the barrier is cross-cultural care, right? Specific example. Many times I've seen this happen in clinical settings, and I've seen it happen in educational settings, where the nurse will say, the patient is not responding well to the treatment. And the physician will say, are you questioning my diagnosis and care treatment plan? And the answer to that, of course, is no. One of the unique aspects of what a nurse is trained in is being able to diagnose and treat how the patient is responding to the care and the treatment plan. So the simple aspect of maybe you can use the same language of saying the patient's having difficulty with the treatment could mean they're not responding well to your treatment. It's not a question of your ability to diagnose and come up with a treatment plan for the disease, but the patient is having difficulty responding to or following through in that care plan. So being able to think about what's the lens, help me understand, what do you mean? And being able to ask different questions and value that other people are looking at these things from a different lens can be very helpful. For the medical students that we're talking to, the other one that you can realize is that when you get to residency, every residency director will be looking at you as an intern to determine whether or not you have entrustable professional behaviors. What that means is, can I trust you to go in and do a basic exam or engage with the patient in multiple different ways? I believe there's a total of 13 or 14 different EPA categories, and each one of them have multiple competencies underneath. There's a great document, you can look it up on the link that's there, and it describes pre-entrustable behaviors, means I can't trust you to go in and do this by yourself. And entrustable behaviors, which means the attendant can say, or the resident can say, yes, as a new intern, go ahead and go do this. The big ones around teamwork have to do with patient handoffs and transitions of care, actually specifically collaborating as a member of an interprofessional team, and then having a systems approach or lens or experience being able to contribute to saying, how do we improve our culture of safety? So these are where we have built in specific behaviors into our learning programs that better prepare our students. One way that you can stand out against the thousands of other candidates who are striving for those residencies that you want is not only to know the language, but have experience of actually practicing some of these behaviors and working through how you can demonstrate your ability to contribute to them effectively. Okay. This is an article if you want to read, again, more about some of the things that Dr. Rotnick and I are doing in that course and at St. Louis University. What I want to do is jump now to the question and answers. I did get some great questions that came in, and then if there's others, please feel free. And if anybody wants to go off of mute and say there's a different question or there's something else that you want to ask about what I'm sharing, just let me know. First question was, who can lead an interprofessional practice or a QI for team-based care? And the answer to that is anybody. It is ideal if there are systems support. If we don't take a look at this on a systems level, then we keep just overloading, thinking that it's an individual responsibility. So the system and whoever's leading that department or the residency program or the clinic or those types of things, there has to be a desire to look at things in a systems-wide approach. That doesn't mean that you as individual providers can't contribute to that or bring up excellent questions or help to identify barriers in the system that are blocking you from providing better care, all right? Specific example, and this one kind of combines who can do it with value and cost. I work closely with our program director for our general internal medicine residency program. We sit on a quality and patient safety steering committee for the clinical practice, and we've done some QI projects together. She was asked as the residency program director, saying, look, you got to cut the cost of your program in terms of the cost of delivering care. So rather than just look at it from a standpoint of cost reduction, she looked at it from a standpoint of what is it I really want with my internal medicine residents. I want them to be better physicians. I want them to be able to be critical thinkers, and how are they utilizing the data they have, and are they effectively utilizing that information or labs to change care. And one of the things that she specifically looked at was daily ordering of labs. And she asked the attendings and she asked the residents and did some observation, and basically saw that people just order them because that's what you do. Order these labs every day, right? But she started talking to the residents and talking to the attendings and said, you know what? We get these labs every day, but it doesn't necessarily change the care that we do with the patient, right? We just look at them and say, oh yeah, labs are this, but we don't do anything different. What if you made a conscious choice to do those every other day? Would that still be getting you the good quality information you need, and or the enhancing your ability to make good medical decisions? So she did 4 things. She specifically looked at, how do I train my residents to ask better questions and figure out what discussions do they need to have with the attendings to better utilize labs to influence their care decision, right? 2, she went through and then talked to the attendings and said, there's an expectation that we're engaging in this process so that our residents can become better thinkers and clinical decision makers. She then looked at what are the practices that are supported in our electronic health record. Well, the default selection when you're ordering labs was to order them every day, and to order certain labs which were more expensive than others, but didn't necessarily have that information wasn't always being utilized. So they actually worked with the IT and EPIC care team that does the electronic health record. They changed the orders of what shows up on the list when you pull down the menu to saying it's every other day, Monday, Wednesday, Friday, Tuesday, Thursday, or you can select every day. And the priorities of the labs were done based upon what would be getting you the information you need without excessive lab ordering. They did this for a 20-month period, right? In the first period, they started to say, all right, let's just start these changes and see what we get through the first 30 months or so. And then they, over the next, they did a total of almost 2 years, and found that, 1, the amount of discussion and the labs that were being discussed between residents and attendings went up by 90%. 2, the total number of labs went down by 20% that were ordered. But most importantly, the care outcomes that were better, right? And then you say, okay, this is all great, but what was the impact? What she found was that from this one change and how they did things, it ended up being over the 20-month period, they ended up with a $54,000 reduction for every 100 patient days that someone was in the hospital. When she extrapolated that out for the 2 full years, it was a $12 million savings in lab costs for one residency program with one set of labs, right? So looking at, you have to reduce costs by focusing on the value, by focusing on making a better learning experience and developing a system that said, stop, think, and order, and that everyone's becoming a better clinical decision maker. She actually ended up saving $6 million a year for her program, right? Just on one lab change. And now they're trying to extrapolate that out, not only to other care within GIM, but also within other residency programs. So I got a motion detector on my lights there. So again, that anybody can do that. That was headed up by a chief resident and residents and interns with the supervision of the program director. It was not done to say, here's what has to happen at the hospital level, but there was collaboration between the nurses who were looking at taking the labs and getting the orders, filled in terms of blood draws. It was a collaboration with the people who did the electronic health record. It was a collaboration across the residency program with multiple levels of providers. And it was also a documentation with our quality improvement team to be able to see where that can be replicated. So again, just one example that anyone can start these projects, and it's just a matter of having skills. Individual providers, non-hospital systems, absolutely. I gave the example of the community health centers, looking at better ways of doing care, collaborating with, here we've got a big help with behavioral health as well as community health workers, and trying to see how we engage patients better. So there are different ways that providers in non-hospital based systems are doing this. The next one, I would say, in terms of individual actions or individuals pushing ideas up to leadership, change usually happens because someone's passionate about something. Someone's passionate about doing better. Don Berwick, who is a pediatrician by training, but used to be the head of all of CMS, and then the founding director of the Institute for Healthcare Improvement, his perspective was that we all have two jobs in healthcare. You do whatever you're trained to do, and then you continuously focus on how do I do my job better, right? That part of that is how do I do it better to improve the outcomes of what I'm doing and get better results for the effort I'm making with patients. So you can do this in terms of brief huddles. Huddles can happen at any size practice. Who's coming in today? What's happening? What support resources do we need to best care for our patients? Do we need labs? Do we need their self-management records? Who needs to see them in order to be able to get them the best care they need for today? So brief huddles, having a plan for the day, or bigger aspects of quality improvement can happen on multiple levels. But it starts with someone who's passionate about, we can make a difference, I can make a difference, versus waiting for someone in a leadership role to change things. Is there a standard process or model for improvement? There is. One of the biggest drivers for us here in the US is the Institute for Healthcare Improvement in terms of a model for improvement. Somebody had asked also about what are the different factors involved in that. I would encourage you to take a look at, if you go to ihi.org, or search for a framework. There's a white paper called Framework for Safe, Reliable, and Effective Care, and it outlines all the aspects of culture that contribute to culture or practice and performance improvements as being a part of a learning system. And you'll see that there's a lot of different areas that each one of you can be able to contribute. The other thing that's nice about the IHI model is that it actually goes through a process where you can say, how do we identify topic, steps, what is it we're trying to accomplish, and how do we work that cycle of quality improvement that enables you to become a better practitioner, whether that's as an individual, large practice, or a residency or hospital. In terms of the moving from concept to practice, there is literature around individual areas of outcomes. You may not always find it with respect to IPE literature or IPP, but there's changes in cardiovascular outcomes, diabetes outcomes, cancer care outcomes, a variety of different areas where clinicians are engaging and working with other partners across the healthcare system, or different ways at looking at their data, getting better data back that enables them to take action on behalf of all their patients and what's impacting their patients' care. So yes, there is literature that's showing up. It's just not always labeled as IPE literature. There's a tremendous amount of emphasis right now that where this shows up and how it's expected to be delivered in medicine is the accountability at the residency level. So residency programs with milestones and other aspects of performance measures, as well as care outcome expectations, that's where the reinforcement or the accountability is becoming present even today, as well as at the hospitals or practice level. One of the things I would leave you with is taking, from this question, the team norms and psychological safety, is thinking about it in terms of what what are the norms in your own group right now? What do you feel is comfortable to talk about? Is there a place where you can say, learning from errors, talking about them, not to blame, but to create an opportunity to say, how could we do better? And is that safe? Right? Is it a safe place to be able to do that, or is it a scary or psychologically threatening place? Creating a team norm and creating a safe place for learning are very much connected. So whether that's with fellow students, fellow learners, or in your own way of you go into a clinical setting and you ask, if I have questions, what's the best way to ask? How do I best support you as a clinician in this setting? Where can I have debriefing time to be able to learn what to do better and how to communicate more effectively? Some of you have heard about team steps. I know Janet has done a tremendous work. Janet Head has done a tremendous work at Kirksville with this. One of the biggest things that we found here in our pediatric surgery around team steps was, yes, those communication techniques are important. But the one that showed the biggest impact was the I'm safe checklist. Simply be able to say, we created a norm that said, I can hold myself accountable or anybody else on my team accountable to illness, medication, stress, alcohol, fatigue, emotions. If I haven't eaten or eliminated in 8 hours, if I'm exhausted, if I'm just come off a patient that was a dramatic or tragic, outcome, am I at the best to contribute? And that what we found in pediatric surgery is our adverse outcomes dropped from a small amount of 6 per year to 0. And the change was that the team felt it is safe for me to be able to say, I need to step out without feeling judged, or I can hold you accountable to this norm that we agreed upon without criticizing you as a clinician or as a person. So looking at and identifying what are the norms, what's expected, and are they the most effective to help you best practice. I've talked a little bit about the barriers. One thing I do want to talk about more specifically is the models for reimbursement and does it matter? And then if there's any extra questions, we can kind of throw it back to you guys. There is a change, and Medicare and Medicaid is the group that's driving this change initially, but typically private insurance payers follow CMS pretty quickly afterwards, once they've kind of worked out the kinks and shown that it makes a difference. There is if you want to go and look at it, if you just do a Google search for QPP, QPP.gov, you can find the quality payment program. And what that's looking at is identifying how individual providers and healthcare practices will be reimbursed based upon a combination of services provided, the outcomes of those, and the process of improvement that you are engaging in to support an ongoing learning organization of doing care better. When we started, there was a small incentive and a small penalty. CMS started with a plus or minus 2%. So they would increase or decrease your reimbursement rate by 2% depending on where you were. The model has expanded and it is now up to a plus or minus 9%, which is a huge swing. If you say that what you're reimbursed from CMS is an 18% shift or swing in reimbursement amounts. But the focus is not on just we're going to pay you less. The focus is on what do we need to be doing to be able to document both a process of improvement and a specific ways that we are getting to better outcomes. So the QPP outlines different parameters, different things you're looking at, and then working within your own systems to say, how are we doing this? How can we actually make a difference here? For us, I'll share that when we started 2 years ago, we received a $2,000 bonus at the end of the first year. At the second year, that went up to $45,000. At the end of the third year, it's now at $89,000 additional bonus on top of our regular reimbursement because of the fact that we're demonstrating improvement processes and better outcomes. So being able to work at it. One of the things you can very specifically do as a med student is that when you go into a clinical setting, you can ask, what is one of the primary outcomes that you want to see in this clinic? where is it currently in terms of how the clinic is doing, and what are you doing to, or how can I contribute to, what can I learn about helping to make this better, right? Talking to the different people then with a very specific goal during the time that you're on that rotation. The goal here is to get a better outcome in this area. The goal here is to get people out of the hospital at this time and hit our discharge, or the number of days in the hospital and patient, get them to a discharge plan. Reducing the amount of time or risk for infection, whatever it might be. Asking about that and finding out how you can contribute are really important, right? So ways things are done through the electronic health record, ways things are done through team huddles and different things on your rotation. Some of you may be part of already, some of you may be not seeing these done, depending on where you're going through your clinical rotations. But there are a lot of things that you can do. The biggest thing that we have found is that not only has our reimbursement improved, our systems have actually improved. Some of you have been watching the news. We got hit pretty hard as a medical school a couple of years ago with 19 different citations from the LCME. We were doing things, but we weren't documenting the impact and the processes of how we made those things happen. We changed systems dramatically and really worked as a team across the entire medical school, and just passed that all of those citations were removed and our probation status was taken off. So as a team across the entire medical center, administrative, finance, support, clinical, practice, education, all these different areas, in a very short period of time, you can see dramatic change in a system. And changing a system doesn't have to take forever. So with that, I'll end. If there's any other questions that have come up or anything that I didn't address in terms of a question you submitted, please feel free to unmute and let me know. Anybody else have any other questions? Sheila?
I was just going to say I did get a couple that were sent later, and one of them was answered. You answered it during the presentation.
Yep.
But there was a second one, and I didn't know if the student wanted to ask it, so I was kind of waiting. But since there was silence, I think I'm just going to go ahead and ask it.
Yep.
The question is, does integrating a patient's family into the team ever become an issue from your perspective? And if so, what would be a good way to navigate through that situation?
I think it's always a challenge, right? But then the other part you have to realize is that 90% of the time the patient is taking care of themselves. They're with their family and in their community and doing self-management. So how can you best utilize them to be able to identify what's going on with the patient, where you can support? Take a look at the Josie King video from that perspective. They basically did not engage the mom or the family in identifying signs or symptoms in terms of the baby and what was going on. For personally, my dad passed away 2 years ago, but for the last 5 years had very serious Alzheimer's as well as diabetes and other complications. My mom became a primary caregiver. So the level of acuity that people are being sent home, engaging family, really important. It also becomes an ethical issue. Are we truly respecting the autonomy of the person and the family to be able to make choices? The downside is your patient is your patient, right? So if your patient doesn't want to disclose certain things, or you think it's going to be more valuable to the patient's care and outcomes if their family's involved, helping that patient get to that place, understanding why that might be a barrier, those things are all value. I would encourage you, if you haven't seen it, the Agency for Healthcare Research and Quality, AHRQ, has a great simple process for shared decision-making, SHARE, it's an acronym, but being able to think about how do we engage, what works for our patient, who is helping that patient and supporting them, really essential. The challenges are more on the downside. One of our chief residents who was facilitating a session, the patient had a conflicting advanced directives. I want no heroic measures unless the person I've given power of attorney to or power of healthcare decisions making to says to keep doing it. So the family said, let him go. and they called the sister who was the person with the health directives, and she said, no, I'm on my way, don't do that. The family and the sister argued for an hour while the entire team had to do CPR and try to resuscitate the patient until they finally resolved their conflict. So engaging the family, there's upsides and downsides. Families aren't always perfect. There is no perfect patient either. So how do we come up together with them to better care for them? Always an ongoing challenge.
Thank you, David. I appreciate that. Anybody else have a question that wasn't answered during the presentation?
Again, the main thing I would hope is that whether it's from the 5 points with Mitchell or with something, that you start to think about what's one thing that you could do differently. If you haven't heard already as a med student, when you get to residency, there's an acronym called RHYME, right? By a show of hands, how many people have heard RHYME? Nobody. Okay. Are you a good reporter, interpreter, manager, and evaluator or educator around patient data? In your third year, by the end of your fourth year, you should be an excellent reporter of information, that you can gather information, report to your resident, your attending, and be able to convey really good information about what's working for the patient, what's not, what are the signs and symptoms. As you enter into your residency, your ability to interpret that data is going to continue to build. So if you're looking ahead, how do I report really well? Means I have to ask questions really well. How do I start to interpret that? It's helping the residency attendees get out of their head around what's going on, asking better questions. When you get up to the residency level, then you're going to be responsible for managing that independently. And then you're going to say, how do I evaluate this progress and continue to do it better? Learning quality improvement, learning communications, learning what are good questions sets you up to be an outstanding intern. So I hope that when you go into your practice, wherever you're operating clinically, start asking, think about what different questions can you ask? How can you learn the most, get the most out, or contribute to what the team is doing to improve the quality of care in that clinical setting? Anything else? Well, I really appreciate the opportunity to talk to you guys. Hopefully some of this was a reinforcement of what you've heard. Some of it might have been just new or different stories. But regardless of where you practice, what specialty you go into, you will be a member of a team. That's where healthcare is going. You may be a team of all physicians. You may be a team of, you're the sole physician in a rural area and you have to work with other professionals across the spectrum of who is there. So working together, collaborating well, and utilizing other people to the full scope of your ability is important, right? The flip side of that is, what does it look like? My wife's cousin became an OBGYN. At the end of his residency program, he was excited about starting practice, and his residency director said, "Oh, you're signing up for the fellowship in oncology." And he said, "No, I'm getting a job." And he said, "I'm sorry, you thought that was a question." Right? So he did an oncology fellowship. And then he found that he was caring for these women across their spectrum of starting off early, delivering babies, dealing with cancer and other treatment, and that he was having a tough time with working with surgeons. So he became board certified in basic surgery so he could do all that work himself. He is now completely burned out and has left medicine completely. He's a great man. He's done phenomenal work over his career, but he can no longer practice. Doing it by yourself is not going to keep us all going, and being able to engage other people to be more effective with our patients and helping us be well throughout the career that you want. Really important. So again, thank you very much. Good luck with the rest of your clinical work.
Thank you very much, Dr. Pohl. We really appreciate it. Okay.
Thank
we will, yeah, go ahead and adjourn. Marcy, is there anything else you wanted to say?
No, just want to thank Dr. Pohl for presenting today. It was a great lecture.
Okay.
Excellent.
I couldn't talk to you directly, and to make this more dialogue.
Yeah.
Maybe some other time.
All right.
evaluation comments, Dr. Pohl said he'd appreciate. So
Yes, absolutely. Thank
at
you.
your sites, that'd be helpful.
All right. Thanks so much, everybody. Have a good day.
Thank you, you too.